Yes, please. Thank you. Oh, great.
And while we're waiting for representatives to come down, Jane, do we have you on the phone? Welcome to the House Healthcare Committee here in Oregon.
Hi.
Welcome back. Thank you.
Hi, Sam. How you doing? I've had better days. Hi, Jane Horvath.
Hey, how are you? Representative Nose?
Yep.
Hi.
Chair Salinas, Vice Chair Hayden, members of the committee, thank you for the opportunity to talk to you about what I think is a very innovative and maybe aggressive concept that we probably couldn't have gotten across the finish line in this session. And maybe after we see the impact of House Bill 4005 this summer when the report comes out, we can take a stab at this approach. And I look forward to working with Rep. Prusak and others on a bill like this for 2021. So in my opinion, the holy grail on the politically progressive side is single payer or universal coverage or Medicare for all, where all of us have coverage and can see a provider and go to the hospital and be treated with needed medicines. But without cost containment and utilization controls, any single payer or tax-funded system will be overwhelmed, I believe, by the cost challenges of paying for all this, just as the current system is. Especially as medicine continues to innovate and initial innovation is expensive. And as we all know, and I certainly know, thanks to Chair Greenlick, this is especially true for pharmaceuticals. Now, some of you may recall that my first foray into cost containment with prescription drugs was not House Bill 4005, but it was House Bill 2387 from my 2017 session. House Bill 2387 was a product of a work group that I led for almost a year and a half, again, thanks to Rep. Greenlick, that never came to a consensus about what to do. The bill did do three things. It capped copays on insurance plans, copays for drugs so that patients could have a reasonable cost share and know what they would pay when they were prescribed something. It required price transparency, which we did get, for increases on drugs above a certain threshold, so we'd know why a price was going up. And it required rebates to insurance companies when pharmaceutical manufacturers charge too much for their products. Now, there was a whole process for how we would negotiate that and examine that, and I don't think we need to spend our time talking about that, but like it would have been very elaborate and robust, run by the Department of Consumer and Business Services. Now, the bill died for a lot of reasons. Are there any pharmaceutical lobbyists behind me? Because I think they believe that they killed it. But really, it was... maybe there's a few. Everybody's got a pharmaceutical client. But I think it died more from a lack of time to work out how we would pay for it, how the agency could implement it. You know, it had ways and means challenges. All right. It's a complex idea. So House Bill 2696, I think, is another bill aimed at actually containing prescription drug prices, but instead of a rebate approach, it takes a rate setting, or as I've been told to call it, an upper price limit approach. As you are likely aware, excessive price increases of prescription drugs jeopardize the financial stability and health outcomes for Oregonians. Price hikes also contribute to the increasing cost of health insurance and put undue burden on the health plan and other state health plans. I'll just make a little plug for 2678 while I'm here. The bill establishes a 7-member drug cost review commission, which would set price caps. Yes, Chair Hayden, or Vice Chair Hayden, I was looking at you. Sets price caps and track changes on the cost of prescription drugs, and an 11-member advisory committee will assist with these functions. The bill requires manufacturers to provide written 30-day notice to that advisory committee when wholesale prices increase for a full course of treatment and are projected to exceed certain specified thresholds within a 12-month period. I could kind of go through that. And there's, 30-day notice. If the commission determines that a cost increase is unjustified or unduly burdensome to Oregonians, the commission will establish a maximum payment rate for the drug. If a drug company or distributor exceeds that established maximum rate, the Attorney General can investigate and can take legal action according to ORS 646.607, the Unlawful Trade Practice Act. Kind of like what DCBS already does with insurance, or what the Public Utility Commission does when they set rates. The Attorney General will also advise pharmacies, administering providers, wholesalers, and other related parties of the legal constraints regarding drug pricing under the bill. Funding for the commission would be provided through the state treasury, separate and distinct from the general fund. Going forward, the commission would be responsible for developing a plan for funding its operations, blah, blah, blah. You get the idea, okay? Jane, did I do a good job of explaining it?
Yes, very good.
Okay, because it's model legislation, and you're going to explain a little bit more about what's going on with that, right?
Yes.
So should we have Jane Horvath go next, or did you want to go Representative Prusak?
Whatever you prefer. I had planned to kind of tag along to what he just did.
Okay,
and then
yeah, why
have
don't we
her
go ahead and
be-
hear from you?
answer all the
Yeah,
questions.
thank you.
Okay. So for the record, Rachel Prusak, House District 37. We've had a really long day. I'm going to try my best. I imagined this being all of the committee members and a lot of people here, but I'm going to do my best, just like Representative Noce did. So during the last 18 weeks, we've heard a lot about how the primary drivers of healthcare cost is prescription medication. We've also voted on many bills, presented solutions for the cost, for example, 60-day notice, importation, and several others. So, fellow committee members, we've done some great work in our limited time here. However, none of the prescription bills actually address the increased price tag pharmaceutical companies place on medication for more profit. That is because this bill is a heavy lift. And while it is a heavy lift, I believe it is the future, and I hope the future for Oregon. I will let our expert, Jane, present what states have started looking at doing this and what we can learn from the states that have already made attempts. Representative Noce already outlined the plans for how the bill would work, and I wanted to touch upon some of the challenges we ran into with the current language and what we would do to improve the bill moving forward. So when I decided to resuscitate House Bill 2696 of Representative Noce and sign on to it, it's for the reasons that I mentioned. I felt like we've done a lot of work, but none of them was addressing the big problem.
It's good to have a nurse practitioner resuscitate your bill.
Thanks for reminding everyone I'm a nurse practitioner, too. So I met with everyone and anyone that would talk to me. I hustled for weeks to try to keep this bill alive and potentially pass it this session. We now know we're having an informational with the hopes for 2021. But I met with DCBS, the Attorney General's office, Department of Justice, OHA, the Governor's office, and I hustled because I was hopeful. But from those meetings, I had planned to propose 2 amendments. And because we didn't hold a work session, none of you will see them. So I'm just going to let you know what they would have been. The first amendment would have been to remove Section 8, 9, and 10. These sections are related to the drug cost review process, focusing on the manufacturer's responsibility to notify the commission in the event of a price increase, as well as a submitted justification for the price change. The reason for their removal is due to their duplicative language. Here in Oregon, we already are doing this because of Representative Noce's great work with House Bill 4005. The second amendment would edit Section 14, which focuses on the investigation of any complaints of payment rates. The original language gives the responsibility to the Attorney General. However, when pursuing this project, as I mentioned, we learned that they didn't feel comfortable with this task. But I think one of the things Jane's going to speak to as well is she's been meeting with Attorney Generals, and she plans to come here to meet with ours to hopefully prove that we can do this, okay, and not get sued.
Well, if we get sued, we're going to get sued.
Okay, we'll get sued and
We're
we'll
going to
win.
get sued. That's what the pharmaceutical industry does. Sorry.
No, I love it.
Right?
Well, we hope.
And the lawsuit, yes.
They provide some other services too.
And we want them to continue to. But the other amendment would be to remove the fiscal, since as we know, this helps with passage of bills. So the last amendment I had made was to increase the cost of the pharmacy license fees to pay for the commission. Prescription medications are something most of us at some point in our life will need access to, and sometimes it will be life or death. And it is important that we control the rising prices. And I believe that a Drug Cost Review Commission is a necessary step to ensure Oregonians have access to affordable health care. We no longer will be the first that does this, because Jane will speak to it, but I hope that we do in 2021. Thank you.
Thank you. Jane, do you want to go ahead?
Sure. And I just wanted to say thank you very much for the opportunity to talk about this. And you can ask me questions as I go along, however you prefer. And I just wanted to speak generally to the model itself, and as the different states have been working with the model and making different changes to it, as has been done in Oregon with the bill that was offered up this session. So the basics of a prescription drug affordability board or rate review commission is affordability. And it is not getting into the question of the value of a drug. All these drugs are very valuable because they preserve and enhance life. But assessing value on a product is in the eye of the beholder, and there's not a lot of consensus yet about how you address or assess the value of a particular drug, like the monetary value of it. But affordability is a more clear-cut standard, and it's like, at what cost to payers and to patients could everybody who needs the drug get access to the drug without being fearful of financial ruin? And affordability, the whole concept presumes that more people are actually going to be able to have access to drugs, so there'll be more sales of drugs rather than less sales of drugs. And there's no intent in this design to have manufacturers lose money at all. It really is gaining access to affordable products. And as Representative Nose, I believe, had mentioned, this is very similar to the state public services commissions that every state has, and that model of assessing what is affordable for consumers and the consumer rates that will be charged goes back to early in the 1900s. And every state still has these public service commissions. And it varies with the state, but in general, it's like a 5-person board of people who are not conflicted, but who have issue area expertise, an advisory council of stakeholders who come with their biases and their views. That's the role of the advisory council. And it can be whatever number of people is satisfactory in Oregon that make sure that everybody's views are heard. There's a monetary threshold for the cost of a product or the price increase in a product that puts the product sort of within the view of the affordability board. And it doesn't mean that a review is actually going to be triggered or anything is going to come of it. It just is thresholds by which the board would ask for public input about whether there should be a more serious review of the affordability of a particular product. And there's different thresholds for brands, biologics, generics, biosimilars, because each of them have sort of a different role in the market sector, and and different things that drive their costs and their price increases. And ultimately, the board, if it were to decide that a drug did pose an affordability challenge for a state healthcare system writ large, so all payers, patients, everybody, it would establish an upper payment limit, and that's the limit at which Oregonians, purchasers and payers in Oregon would pay. And basically, it takes the concept of an upper payment limit, which is just, it's ubiquitous in the healthcare system. Nobody in the healthcare system pays charges. They all set their payment rates, and we go from there. It is just, it's been part of our healthcare system now for decades. And so the board concept takes this idea of setting an upper payment limit and gives it sort of the force of law behind it, so that a pharmacist, for instance, is protected. A pharmacist isn't out there trying to figure out how to negotiate with a McKesson wholesaler to get a cost that then he can turn around or she can turn around and make sure that they are not overcharging their consumers, the patients that come to the counter. And the really important thing about this particular approach is that it lowers the cost of the product at the point of service. It doesn't rely on rebates. Rebates, if the whole system is working well, rebates would become unnecessary. necessary because the drugs would be affordable on the front end. There's no need to compensate payers on the back end for very high-priced products. It makes it more transparent, and again, it eliminates the need for the back-end rebates. And the assessment of the value, the actual value of the product as a clinical matter, as a medical matter, is still left up to the experts, the health plans and their medical directors, the doctors, and all of that. And it's the review process that the board would undergo. I'm sorry, I haven't been saying about the slides. I'm on slide 5. I apologize. The review process, it's very public. They solicit public input. The board is going to have to understand what health plans currently, their net costs for therapeutic alternates in the class, what the health plans anticipate their net cost of this product is going to be, what it would cost to ensure that everybody in their health plan has access who needs access to the drug. Just doing some real on-the-ground assessment, and then figuring out at what payment rates, at what cost could the healthcare system afford to make sure that everybody has this product who is indicated for the product, and patients aren't facing exorbitant co-insureds or co-pays, which in my mind, in today's system, when patients do have very high co-insurance or co-pays, is just a symptom of lack of affordability. And so patient costs would be taken care of in this process too. An optimal system, I'm on page 6, slide 6. An optimal system is that the upper payment limit would be statewide, all payer, all purchaser. That means that nobody's left holding the bag trying to figure out how to wrangle the system to pay only at the upper payment limit and not lose their shirt or not have to pay more and then charge less to be in compliance with the law. And if it's less than statewide, we can get into this another time, but if it is a less than statewide system, if it only applies to government programs, for instance, it's going to have to, as a mechanical matter, it's going to have to rely on rebates rather than upfront point of service, lower costs. And so that's something I would really caution people to think hard about in terms of making it statewide versus not statewide. And then people always ask about enforcement, and in my work with states have different laws on the books. There are consumer protection laws, there are contract law, there are commerce law, some of which can be used to apply in this particular situation. I haven't looked at Oregon's laws in these areas yet, but there is probably things that are useful tools in terms of enforcement if a manufacturer says that they will not sell product in the state, that they will ensure that distribution doesn't come to the state. One viable approach is to import a drug from Canada. The Trump administration is definitely leaning in on importation these days, and federal law actually does allow it if you can construct a program appropriately. So that's one. But I would also say that pharma is not going to stop selling drugs in Oregon or in any other state as a result of this law. Again, there's no financial penalty to the point is to sell more drugs, not less. And in Europe and in Canada and Japan, all of these countries have very direct price controls, and pharma hasn't exited any of those markets yet. And they actually have said as much, that they wouldn't exit these markets, they wouldn't abandon patients. They said that to the U.S. Senate Finance Committee back in February, I believe. So that's the enforcement piece of it. It's a very different approach at the same time that it's a very old-fashioned kind of approach. And this whole concept is designed to not necessarily avoid a legal challenge, but to be successful on a legal challenge in terms of dormant commerce clause and other issues that pharma has raised in legal challenges in other states for other measures that states have taken.
I have to go back to rules.
Thank you.
Jane, this is Repno, so I got to go back to rules, but I just want to thank you for all the advice you've given me on so many things around this topic. I wish I had met you in 2016.
A couple years ago.
Yeah, I would have been a little further along on my bill in 2017, but that's all right. I got to go back.
Okay, thank you. Dr. Metz, and then we'll take any questions.
Thank you. Madam Chair and members of the committee, I'm Samuel Metz. I'm a member of Oregon Physicians for a National Health Program that is delighted that Representative Noce endorses universal care. I'd like to advocate for HB 2696, not by describing it, it's been done quite aptly, but provide the comic relief by showing you how drugs currently get from manufacturers to patients here in Oregon. The first slide I'm going to show you comes from Health Affairs. Now, this is the simplified version. You'll notice the manufacturer is at the top, and there is no place for the patient in this. That's an unhappy commentary. You'll notice that there are no straight lines. You'll notice that there are multiple agencies, public and private, between the manufacturer and the patient. I found this slide to be unusable, so I went to another source, Drug Channels Institute. Dr. Adam Shine is a PhD economist who has been tracking pharmacy benefit managers for years. Unhappily, we've restored the patient down at the bottom where patients frequently end, but it's no clearer. There are different labels, there are different pathways. So I kept searching. This last slide, I promise, comes from the Journal of the American Medical Association. Please note that there are 4 different flows. There's one flow that represents how drugs get from the manufacturer to the patient. That's called distribution. Another separate pathway about how money gets from the patient to the manufacturer. That's called payment. A third entirely different pathway is the legal responsibility for providing drugs. That's called service. And lastly, the pathway that rebates take, and they never really get to the patient. There are 3 take-home messages from this. One is, this is oversimplified. In Oregon, each one of those boxes is represented by dozens of different entities, private and public, each of which has a different independent relationship with the dozens of different entities in every other box. Each one of these boxes represents a business that will protect the flow of money through that box. We cannot change this system without resistance to change from everyone who currently thrives in this system, but you folk are legislators and you already know that. And lastly, we should not delude ourselves into thinking that we can make a small change to one of those arrows and expect that patients will either have greater access to drugs or lower cost of their drugs. I would round out those chances down to 0. The bottom line is we need the kind of thinking that's going on in HB 2696 to simplify this system, to make it more efficient, to make sure that the end point is greater distribution of needed medications to patients at affordable prices. If we don't do this, then all of us in healthcare policy will be compelled to understand each of those 3 slides. Thank you very much.
Thank you. Are there questions for either Representative Prusak, Dr. Metz, or Jane Horvath? Or any comments? Yes, Representative Prusak.
I was, Jane's still on the phone? Oh, great. Thank you, Chair. Jane, could you speak a little bit to the other states that have passed or in the process?
Yes.
Thank you.
So Maryland is the only state so far that has enacted this bill, and the governor just let it become law without his signature. And the bill went through a significant. It was a 2-year process in Maryland, and the bill went through some significant, or the model went through some significant changes. At the end of the day, the bill that they have created is a 5-member drug affordability board, and in the first 2 years, the board is looking only at state, county, and local government payers and purchasers, so state hospitals, employee plans, not necessarily retiree hands, but university health systems and clinics, first responders, things like that, and trying to set affordability limits on different drugs that are really driving some of the budgets in the state. And then coming back to the legislature in 2 years with a proposal for taking the upper payment limits statewide and like a more fulsome vetting of the legal challenges that might be involved, how it would be approached. And during these 4 years, the board will be establishing its methodology for looking at affordability, assessing affordability, setting up its methodology and criteria for setting an upper payment limit and things like that. So in this interim period before they go back to ask for full statewide authority, a lot of what they do and how they do it will be known and have been a very public process. So that's the only state that has passed it. It is being debated in Massachusetts. There's a hearing on it in New Jersey on Monday. It is also being discussed. There is a proposal that is working its way through the system now in Maine. It's had a bunch of hearings, and there is a package of bills that is moving forward, and a drug affordability board is part of that package.
Thank you.
Great. Any other questions or comments? All right, can we call up the next panel?
Madam Chair, we can. We have John Mullen, Numi Lee Griffith, and Katie Thyssen.
Thank you, Madam Chair, members of the committee. For the record, John Mullen here on behalf of AARP. And just would mention to begin with that the mission of AARP is to enhance the quality of life for all of us as we age. And our 510,000 members in the state of Oregon are very concerned about prescription drug prices. But I also want to say that in the interest of time, I want to also begin with thanks to Representative Prusak. And I'm not going to go through my testimony in detail, as this has been a long day for everybody. But I really do want to stress the fact that we are supporting a number of prescription drug bills during this session, and we're interested to see the 60-day notice bill and the drug importation bill get across the finish line. Having said that, those are some small steps towards the issue that is at hand. If you look at, get a chance to take a look at the AARP testimony, you'll see information there about how much this means to a person on a fixed income to have price increases for prescription drugs. And because of the changing modalities of treatment and drugs that come on the market, this is going to be an issue for years and years to come. We've often talked about the fact that we have seen very little action at the federal level. There has been a little bit of an uptick with advertising and drug importation at the national level, at least giving a go-ahead to have some movement along those lines. But I think to truly have a breakthrough, something like this bill with looking at having a regulatory authority could be potentially a huge breakthrough. So with that, and again, in interest of time, I'm just going to go ahead and end the testimony there, but thanking all of you for staying late today and taking some time to think about a very difficult issue. I know that AARP will be interested to stay engaged and involved after the session. It won't be me, but...
Sure it won't. Yes, we have.
But in any case, it's something as a citizen, I will certainly be interested to follow, and I would love to see some innovation here in the state of Oregon as far as prescription drugs are concerned. So thank you very much.
Thank you.
Good afternoon, Chair Salinas, Vice Chair Hayden, and members of the committee. For the record, my name is Numi Lee Griffith. I'm the healthcare advocate for the Oregon State Public Interest Research Group, commonly known as OSPRG. I want to take a moment to note that as I've previously addressed this committee under a different persona, and this is my first time providing testimony as myself, should you need to address me, I do prefer feminine pronouns, and I appreciate your accommodation of this if it becomes necessary. OSPRG is a consumer advocacy organization with over 30,000 members and supporters throughout the state of Oregon. Over the last 3 years, we have helped lead Oregon's legislative efforts to rein in the high cost of prescription drugs, including supported passage of the landmark Drug Price Transparency Act in 2018 and advocating in favor of multiple concepts during the current session. We've seen the need for real action to rein in drug prices through our work on health insurance rates. The cost of prescription drugs, which rose at 10 times the rate of inflation over the last 5 years, has proven a persistent obstacle to keeping health insurance affordable for Oregon's consumers. This has proven true again in this year's rate filings, with some insurers claiming a cost growth trend as high as 13% for prescription drugs, substantially higher than the estimated trend for all other aspects of care. OSPRG and our national affiliate, USPIRG, have built our healthcare program on around a simple principle. As a nation, we need to increase the value of care. That is, the price we pay for treatment should reflect the therapeutic value of the care received. The unique dynamics of healthcare consumption, including the role of health plans as intermediate payers and the inflexibility of patient demand, mean that market forces have proven ineffective at keeping the cost of care in line with its therapeutic value. This is particularly true when it comes to prescription drugs. Our 501c3 sister organization, OSPRG Foundation, surveyed the price of several common prescriptions and the generic equivalents at over 250 pharmacies across 11 states. For its recent report, The Real Price of Medications, I've submitted this report as an exhibit for your reference, and I encourage you to take a look at it. This survey found incredible variance in prices for prescription drugs. Our researchers found prices as high as $865 and as low as $193 for the high cholesterol drug Lipitor. The generic alternative, atorvastatin, had prices as high as $393 and as low as $8. It's ludicrous to think that Lipitor can remain on the market with a median price 350% higher than atorvastatin 7 years after the alternative generic, which is supposed to bring down prices, was introduced. This is just one demonstration of how the prescription drug market is fundamentally broken and disconnected from relative value of care. We pay more for prescriptions than any other nation in the world. The reason for this is not a mystery. When the state of Florida examined the potential costs and benefits of establishing a Canadian importation program this year, it concluded that rate setting, like the proposal embodied in this bill, has a role in controlling costs in every other country that has a modern healthcare system. Also this month, the state of Maryland, as was mentioned before, became the first in the nation to recognize the failure of the market to bring drug prices in line with the therapeutic value by creating a drug price affordability board similar to the commission described by this bill. We have recommended many different policies to address the issue of drug prices, from expanding importation to creating an expert board to examine drug prices, much like this bill proposes. We believe this concept is worthy of further discussion, and the experience of Maryland affords us a great opportunity to observe this type of proposal in action and hopefully have the opportunity to discuss this further in the years to come. Thanks for your time and consideration.
Thank you.
Chair Salinas, members of the committee, Katie Tyson with the Oregon Nurses Association. Really just want to thank you all for having this conversation today. I think ONA has been at the table because we really want encourage you to use every tool in your toolbox to manage costs and make prescription drugs truly accessible for Oregonians. And I'll echo a lot of what John said. We're at the table on a number of bills this session because, and I think I've said this to you before, but ONA nurses experience every day their patients cutting pills in half, making choices between paying rent and taking their drugs, and that's just unacceptable. And ultimately, high drug costs ultimately raise costs for everyone because the state is paying, for increased costs in Medicaid and Medicare, and also just through increased premiums. So wanted to come to the table today because this is a really significant and common sense tool that we think the legislature can use in establishing a statewide upper payment limits through a prescription drug affordability board as outlined through the bill. So I think, price control commissions are a tested concept that have worked in other industries, in regulating consumer costs for products that are essential to health and safety. So like affordable, clean drinking water, right? Like clean drinking water, life-saving drugs are not a commodity or a luxury. They are a public good, and their prices should be subject to pragmatic and a democratic process. So I think by duplicating that sort of process that's already working in a lot of other public goods. It would establish a base level of fairness and democracy in this process, which would be critical, and really help bolster patient trust by soliciting input from patients, providers, and health plans through the review process, as Jane was talking about. So again, really just want to, I know it's been a long day for all of us, so thanks for taking the time to discuss this issue, and really encourage you to work on it through the interim and into the next legislative session.
Thank you. Are there questions for this panel? All right, thank you. I'm sure this is not the last that we will hear of this issue, and yeah, I'm excited to continue to work on it. Thank you. Anybody else, Oliver?
Madam Chair, no, that's it.
Okay. Is Jane still on the line?
Nope.
Okay.
Sorry.
Well,
Do we have, are there further informational meetings already scheduled?
I believe there are. Oliver, what do we, I'm not keeping up on our calendar, I'm so sorry.
I don't have an accurate list right now. It's in flux as of 1 o'clock today, Representative Green, but we're trying to get the intent is to have more information next week. We're trying to pin them down by tomorrow so we can get it posted for next week.
Yes. And yeah, and I think some of it is also pending floor schedules as we move forward.
Yeah.
All right. Well, thank you, committee members. And with that, we will close the informational hearings in the House Healthcare Committee, and we are adjourned.